Hello everyone. Today I want to brief you about RH incompatibility, one of the most common problems that occur in obstetrics. And before starting discuss about RH incompatibility, I will try to brief you with blood grouping system and how the offspring of married couple inherit blood type. As it is known, blood is grouped by different system, and one of the well-known is ABO system. By ABO system, blood group is grouped as group B, group A, blood group O, blood group AB. And the other way of classifying blood group is based on the RH factor, based on the presence of D antigen on the surface of RBC cells. Based on this, if RBCs have D antigen, they are said to have RH positive, and if they have no D antigen, they are said to be RH negative. Based on this, ABO blood grouping system is regrouped as those having RH factor or D antigen are said to be positive blood group, like A positive, B positive, blood group AB positive, blood group O positive. But if they have no RH factor or D antigen, they are grouped as negative blood groups. Blood group A negative, blood group B negative, blood group AB negative, or blood group O negative. The next step, we'll see how the offspring of married couples inherit blood group. If the RH positive man marries RH positive woman, almost all their children will have positive blood group. And so, because the mother is RH positive and all the babies are RH positive, because they might be compatible with RH factor, because they are positive and they have D antigen, there will be no problem to the offsprings. The second is if the husband is RH negative and the wife is also RH negative, and if she conceived, the offsprings will have all RH negative. And because the mother has no RH factor and the offsprings have no RH factor, and they are compatible, and so no problem will occur to the fetus. The other is if the father is RH negative and marries to RH positive woman, and if she conceived, the offspring is born from this couple, half of them will have RH negative and half of them will have RH positive. And because the mother is RH positive and the fetus have those of fetus who have no RH factor and they are negative, there will no problem occur. And among those offspring is a positive blood group which is similar to that of the mother, so in this case also no problem will occur to the fetus during pregnancy or during labor. The problem occurs if the husband is RH positive and marries to RH negative woman. Here RH group incompatibility occurs. This happens when RH positive husband marries RH negative woman, half of the children will have RH positive blood group and half of them might have RH negative. Among offsprings born with RH negative, because they have no D antigen and the mother has no D antigen, there will not be no problem. The problem occurs among fetus that are conceived with positive RH factor. That means of those who have inherited the blood group RH factor of the husband. So in this time there will be a risk of RH incompatibility if the husband is RH positive and the mother is RH negative, and the conceived fetus has blood group RH factor, that RH positive. Because this RH positive fetus have blood group with D antigen but the mother has no D antigen, here RH incompatibility will occur and RH isolation risk will be set. So as a general, if the mother is RH negative and the fetus is also Rh negative, because both have no D antigen and there will not be Rh incompatibility. If the mother is Rh negative and conceived Rh positive fetus, because the fetus has D antigen but the mother has no D antigen, so if there is a risk of fetal-maternal hemorrhage due to different factors, fetal RBC might cross placenta and enter to maternal circulation. And this fetal RBC that enter to maternal circulation has D antigen, which is foreign to the mother, and now the mother start to produce antibody to clear out these cells. And these antibodies might stay throughout her life as memory cells, and whenever she conceives Rh negative, because it is similar to that of her blood group, no problem will occur. But whenever she conceives Rh positive factor, her memory cells start to reproduce antibodies, and these antibodies might cross placenta and damage fetal RBCs, resulting fetal anemia. So what is actually known is, as it is known, the fetus in the uterus get oxygen and the nutrients through the placenta by umbilical veins, and wastes and the carbon dioxide are excreted from the fetus through umbilical artery through placenta. In placental circulation, fetal RBCs does not come in contact with maternal circulation because there is placenta blood barrier, no communication between fetal blood and the maternal blood. Transport of substance and the gas takes place by passive transport and active transport. But if there is anything that damages this placental blood barrier, then fetal blood might enter to maternal circulation. Like in a case if the mother has history of ectopic pregnancy, if she has abruptio placenta or placenta previa, or trauma to her abdomen which can damage the placenta, if she has history of intrauterine fetal death or any obstetric procedures like amniocentesis, external cephalic version, if there is history of abortion, especially in the induced abortion, or if it is completed by manual vacuum aspirator, in this case, if the mother is Rh negative and the baby has Rh positive, because damage to placenta barrier will occur, and so fetal-maternal hemorrhage will take place. So fetal RBCs might enter to maternal circulation, and this induces production of antibody by mother. And so this antibody production usually takes months, and with the first pregnancy, most of the time this damage to the fetus is less. But with subsequent pregnancy, because the mother now has memory cells, memory antibodies, and these memory antibodies will be produced rapidly whenever she conceives Rh positive fetus. And though this Rh positive fetus will enter to maternal circulation and damage fetal RBCs by hemolysis, resulting fetal anemia, fetal hyperbilirubinemia, and when the fetus delivered, the fetus is at risk of developing kernicterus and its complications like hypotonia, hearing loss, mental retardation. And this risk of sensitization, maternal sensitization, and damage to the fetus increases with subsequent pregnancy. The severity increases with subsequent pregnancy whenever she conceives fetus with Rh positive, because now she has already produced memory antibodies which can early in gestation pass through placenta and damage fetal RBCs. So how can we prevent and manage this? Is during NEC follow-up or antenatal care follow-up for all mothers, blood group and the Rh factor should be determined. And if blood group of the wife is Rh negative, the next step is we need to determine blood group of the husband. If the blood group of the husband is also negative, because the mother is negative, the husband is negative, most of the time they have negative babies and there will not be any problem. But if the blood group of the wife is Rh negative and the blood group of the husband is Rh positive, there will be a chance of conceiving Rh positive baby. So the mother should be checked whether she is sensitized or not. If she has no history of previous delivery or previous abortion or history of blood transfusion, and if she's Rh negative, we need to give her anti-D. And this anti-D is given one at 7 months of amenorrhea, that means between gestational age of 28 weeks to 34 weeks. Then at the time of delivery, we need to check blood group of the fetus, the newborn. And if the blood group of the newborn is negative, because it is similar to that of the mother, no need to give anti-D. And if blood group of the fetus is positive, during labor and delivery there might be fetal maternal hemorrhage risk, and so to prevent maternal sensitization we need to give anti-D for the mother. And what we should know is that anti-D we give is to prevent the risk of Rh sensitization with subsequent pregnancy. Whenever she became pregnant, we check and provide anti-D, because anti-D is not has no long-term effect. But if the mother is Rh negative and the husband is Rh positive, and if she has history of previous delivery or abortion or history of blood transfusion, we need to check whether she is already sensitized with previous deliveries or abortions or transfusion. So in this case, what we do is we do COMBS test to check whether the mother is already sensitized and producing antibody. If the mother has not produced a COMBS test is negative, that means it doesn't produce antibody, like we manage, like I've already said, by providing anti-D at 7 months of amenorrhea and at that time of delivery. But if the COMBS test is positive, that means the mother is sensitized with previous deliveries. This mother needs special follow-up and care, and so should be referred to area centers where are specialists in caring for this type of patients. With this, it is the end of the session. Thank you.